I like the heart because it's simple. And so I think about it and I break it down into basically it's just a pump with some pipes that are a plumbing system and an electrical system. So if you think about it that way, you can kind of categorize heart disease into one of those groups. And you may have issues with all three of them or one out of three, but that's kind of how I think about the heart. And it actually is kind of helpful, I think, even as a patient, to understand the organ that you're talking about, and because there's different ways that we treat those. So I thought I would just go through. So when we're talking about the pump, we're talking about the fact that the heart, and this is a unnecessarily complex picture, but we're talking about the fact that the heart is literally just a pump. So it pumps blood from, returning from your body out into your lungs where it gets oxygen, comes back from the lungs, and then it pumps it out to your body. So there's 4 chambers. So you'll hear us talk about, so the atria are these little chambers up the top. The ventricles are really, when we talk about the pump of somebody's heart, we talk about the ventricles. They do the heavy lifting. And then you have valves separating all 4 chambers. The plumbing system is the coronary arteries. So the heart, the pump, is a muscle. So here, this is like the heart cut in half. So this muscle, and just like every other muscle, your bicep, your quad, it has to get blood flow. And so the blood flow that gives blood flow to the heart muscle is called the coronary arteries. So they actually sit on top of the heart. And so that's the plumbing system. And then the electrical system resides kind of within what we call the myocardium, which is the fancy word for heart muscle. And basically, that's your electrical system. So it starts up top with this thing called the SA node. And that's what tells your heart to either have a heart rate of 50 when you're sleeping and resting, or 150 when you're racing up Vail Mountain or running from a mountain lion. And then that gets translated through this AV node, which then translates what your heart thinks its heart rate should be to what it actually is, because that's what triggers the pump to contract, to squeeze. So if you just break it down, it's just a pump with plumbing and an electrical system. So when we talk about heart disease, there's like a billion different types of heart disease. It would be like saying, I don't know what's in that, like cars. There's like a billion different types of cars. But some of the most common are going to be things that affect the plumbing, the pump, or the electrical system. So when we think about heart disease, to be honest, most people in the United States are talking about coronary artery disease, or CAD. So that's plaque buildup, which we call atherosclerotic plaque, and that's in the plumbing system. Heart failure is a problem with the pump. So when we talk about heart failure, we're talking about that your pump doesn't work very well. It either doesn't squeeze very well or it doesn't relax very well, and then that causes symptoms. The systolic is the squeeze or the pumping. Diastolic is the relaxing. And then arrhythmias are the problem that you can get with your electrical system. And so that can include a whole slew of arrhythmias. So if you think about it as 3 different, functions, any one of them can have a problem, and they're all pretty common. So coronary artery disease, I'm going to spend probably the most time talking about this, A, because it's the most common, and B, it's my personal fan favorite because I care for a lot of patients with coronary disease, because this is how I'm a plumber. So coronary artery disease is a problem with the pipes, and it's the underlying process for most heart attacks and strokes. It's the leading cause of death in the United States. 1 person dies every 34 seconds from a heart attack. So these are statistics off the CDC website, which are pretty interesting to look at. And in 2020, which in retrospect, as I was putting these slides together last night, 2020 was a weird year, but I think it still stands pretty true that, what they attributed 1 in every 5 deaths to coronary disease. So it's incredibly prevalent. And this is what we're talking about with coronary disease, so the atherosclerotic plaque. So if this is one of your arteries, and it's important that we differentiate arteries and veins. So for this, we're talking about arteries. So this is a normal blood vessel, and you can see we often think of it as like a single layered thing, but it's actually this thick walled structure. And you have plaque that can build up. And I don't love this picture, but it gets the job done. Because what you can actually have is you can also have plaque that kind of pushes out and makes it not necessarily narrowed. But what we care about is when it narrows. And so these plaques that build up are a combination of cholesterol and a lot of inflammatory cells, crud, for lack of a better term. They can become calcified, which we'll talk about a little bit later on. But so that's what we're talking about as atherosclerotic disease. This process isn't limited to heart arteries, but when it's your heart artery, it can cause a heart attack. When it's maybe an artery in your neck or up in your brain, it can cause a stroke. When it's an artery down in your legs, it can cause lack of blood flow and wounds and pain. So this happens a lot of places. And it's increasing in prevalence. So these are kind of, if you get bored one day and I don't know, you want to like give yourself anxiety or something, you can go on the CDC website and like look up these statistics. So so there's another, there was another map that was supposed to show. I think my animations aren't working, which may make for an interesting presentation. Yes, the animations aren't working. So before this, there's a map of the whole United States. And what you can see, basically, the CDC gathers information about the prevalence of coronary disease. And in this setting, you want to be one of these counties that is like white. That means you have a low prevalence. If you're this super dark maroon, you have a high prevalence. And if you look at the United States as a whole, there is a huge geographic like variability and distribution. So not totally unexpected by all those articles we read about, like, you know, fried okra and fried chicken, it, you know, is not good for you. The, you know, kind of the southeast area of the United States has a really high prevalence of heart disease, as does kind of both of the coasts and some of other pockets. And so people, you know, when a lot of us went through our training in Colorado, they said, like, why are you going to go be a cardiologist in Colorado? Everybody's so healthy. We're not immune. And so it's increasing in prevalence everywhere. And so this is just looking at Colorado. This is from the years 2008 to 2010, and then this is 2018 to 2020. And you see that there's a lot less of these light-colored white counties and a lot more of these dark red maroon. And that's just a trend across the entire United States. You know, and it mirrors a lot of other trends that we see, like obesity and diabetes and all these other things. But it's not going away anytime soon. So there's a lot of risk factors for coronary artery disease. Ones that I wanted to highlight, because they're modifiable. Some of them are not modifiable, meaning some things you can do stuff about, some things you can't. So high blood pressure or hypertension, modifiable. So that's very treatable. High cholesterol, also very treatable. Smoking, more difficult, but absolutely you can stop smoking. It's super hard, but you can do it. Those are the big ones. And then, you know, diabetes, obesity, unhealthy diet, excessive alcohol, sedentary lifestyle. Genetics does play a role. We think about genetics when we hear about first-degree relatives, so that's mom, dad, brothers, sisters, who had some sort of event, like a heart attack, a stroke, a stent, bypass surgery at a young age. Young varies a little bit, but usually we're talking about men in their like 30s and 40s, women in their 40s and 50s. You know, saying like, well, you know, Uncle Jim had a bypass surgery when he was 80. I don't quite know what to make of that. But family history does play a role. And that's always variable too. You know, if you're like, well, maybe it wasn't young, but it's like every single one of my uncles, you know, had stents or something. And so it's important to pay attention to. And then this one is interesting. So I put a little asterisk by it because there's been a lot of articles that I see coming across. You know, every morning I check my email and I get the journal scan of what's hot off the press. And usually it's like silly articles that are like, you know, not moving and eating an unhealthy diet is associated with worse things. I'm like, really? But there's been a lot of research recently about sleep. for a lot of things. I recently gave a women's focused talk with Dr. Barone, who's one of the breast surgeons, and she mentioned that sleep is also being linked to breast cancer. And one of the mental health providers were talking about sleep that's being linked to mental health issues. So cardiovascular disease is not immune from this. So what we know is that in a lot of different ways, sleep is important, both for your risk factors, but potentially for like cardiac disease, de novo, or not necessarily related to like high blood pressure. I think we've all kind of suspected this for a while, but it's nice to see some data going into it. And I think probably more to come. So high blood pressure. So I wanted to touch on a couple of these because they're common things that I see. People come to the clinic and either this is why they're there or this is what we're working on. And so high blood pressure. So high blood pressure is super common. The majority is what we call essential hypertension, which is a funny word. Every once in a while I see somebody say benign hypertension, which I always delete from the medical chart because there's no such thing as benign hypertension. Like you either have hypertension or you don't. And if you have hypertension, it's not good for you. So essential hypertension is what we would call that. And basically what that means is it means that you have high blood pressure. We don't exactly know why. Some combination of genetics, and this is what your body is going to do. Super common. That being said, I always run through the list of things that can be causing you to have high blood pressure that you might not be aware of and that you can reverse. So NSAIDs are a class of medications that include Advil, ibuprofen, Aleve, naproxen, kind of the run-of-the-mill painkillers. Every once in a while, totally fine. If you're using pretty, substantial doses on a daily basis, we certainly see them every once in a while cause high blood pressure, along with some other things. So something to be aware of. I would say maybe once or twice a year, we find a patient that their high blood pressure goes away when they stop taking, 600 milligrams of Advil 3 times a day. Sleep. Sleep, as I mentioned. What is enough sleep? So ideally 8 hours or more. Realistically, I think that's like tough to attain, 7 hours or more. And good quality sleep. If you have sleep apnea and you're not getting good sleep, treating that. But making sure that, we do see also with people who have like night shift jobs, and so they have altered sleep habits because of that, their day and night, that can lead to high blood pressure. So diet is an interesting one, sodium. So sodium also kind of has been getting reinvigorated in the press about, is it good, is it bad, do we care, do we not care? In general, we all have a high sodium diet. So a low sodium diet would be like 2 grams or less a day. The average American is probably like 4 grams. And honestly, over that, like you're kind of abusing salt. That being said, not everybody is like a salt responder. And we know that both from humans and from animal studies. So I try to tell people, be aware of how much salt you're eating, but in general, also just have a heart-healthy diet. And the places that salt sneaks in is basically restaurants. Doesn't matter if it's McDonald's or Elway's, it all has a lot of salt. And then like pre-made, pre-packaged things, canned things, tomato-based items, those are all going to have a lot of salt. And so just kind of being aware about it. Most people don't need to follow necessarily a low sodium diet, but most of us also don't need to be consuming more than is in our normal diet. Weight and exercise. So these are tightly related, and there's some debate about, if you exercise a lot, does that in and of itself lower your blood pressure, or is it the weight loss that usually goes along with exercise that lowers your blood pressure? That's beyond the scope of this debate, but they're both good for you. So keeping a healthy weight and exercising regularly helps. So those are kind of things to be aware of that you can do something about. And then there's a lot of people that like they're doing all the right stuff and they still have high blood pressure. And that's when we treat it. We can treat it with a lot of medications. Importantly, high blood pressure is almost always asymptomatic. So we don't start seeing symptoms from high blood pressure typically until you're like 200s, 220s, like really high blood pressures. So that's why it's important to follow regularly with your doctor. And the natural trend for most people is that as we age, our blood pressure typically goes up. So I have a lot of patients that say, I don't know where this high blood pressure came from. I didn't have high blood pressure. And then I say, well, when did you see the doctor last? Well, there was COVID, and then I was on a vacation, and then there was more COVID. And so it was actually like 5 years ago that they checked their blood pressure. And probably it's been creeping up. And that's normal, So it's important to see your doctor regularly and keep an eye on it. And it's usually easy. I don't know why I said easier. It's usually easy to treat. So if you don't see a doctor, and even if you do, it's actually a really good idea to keep an eye on your blood pressure at home. And that's pretty easy. So this is a screenshot. This is a screenshot from my best friend, Amazon. You can buy a whole lot of blood pressure cuffs. So they're generally cheap, $20 to $30, somewhere in there. That's how much you should pay. The things that I tell people, so this one I think gets touted a lot, this one that's called Omron. To be honest, I think I have, I might have that one or this one. They both have like a ton of good reviews, so that's generally a good sign. So, but the things to know about, get a blood pressure cuff that's for your arm, not for your wrist. They're more reliable. Sometimes people have blood pressure that's higher on one arm than the other. The high one is the real one. So if you're like, oh, well, it's always like 20 points lower on this arm, I'll just go with this arm. Mm-mm. The high one is the real one. And then the way to check it at home is to be seated for at least 5 minutes. I tell people I don't say avoid caffeine, but like if you have coffee in the morning, don't check your blood pressure within about 30 minutes. It probably does raise your blood pressure a little bit. So, just take that out of the equation. So be seated, be rested, legs uncrossed. Did I do that? Got it. Legs uncrossed. And then I really, so I had preeclampsia with my second. And so I had to keep track of my blood pressure afterwards. And it made me a huge fan of keeping a log because it's actually kind of hard to remember what all of your blood pressure readings are. And then you go to the doctor and they're like, so what's your blood pressure been? You're like, there was like a 125. And it's hard to remember. Just get an app on your phone or keep a notebook and a piece of paper and just write them down. Because we also care less about one-off readings and we care more about what's your general trend. A lot of people also ask me about should I check my blood pressure in the morning or in the night? I think it's nice to kind of get a spattering, check it a few times a day. And there is such thing as checking it too much. So some people you can easily get kind of neurotic about it and you'll check it and then it was high. And so you'll check it 5 minutes later and then you'll check it 20 more times that day. And that's too much. So check it, write it down. And then if you're worried about it, call your doctor. Let us deal with it. You don't need to stress about it. We can, you get the data and we'll interpret it and treat it. What should my blood pressure be? I get this question a lot too. So 120s over 70s is probably perfect for most people. The one caveat I would say to this is that sometimes as we age, I'm talking 80s, 90s plus, we tend to ease up on this a little bit because we care a little bit less about if you have tight blood pressure control, and we do worry if your blood pressure is too low. So we don't want to be driving you down too low. But for most people, 120s over 70s is you're perfect. 130s over 80s is okay for most people. We'll kind of keep an eye on it. 140s over 90s is too high. So you can really get down in the weeds with specific numbers and if you have this disease and that disease. But I think this is a pretty good generalization of what numbers are what you're aiming for, what's kind of okay, and what's too high. I also get the question a lot, well, what if my blood pressure is, 100 over 50? If you don't feel bad, I'm okay with it. The caveat to that, I guess, would be if you're on medications to lower your blood pressure, then we could probably back off some stuff. But my blood pressure right now is probably 98 over, 60, and I'm still alive. So A lot of people just naturally have lowish blood pressure, and that's fine. If you're having symptoms of feeling dizzy, feeling lightheaded, passing out, or if you're on meds that you think are driving down your blood pressure too low, that's the time to talk to your doctor. But if you're just one of those people that tends to have low blood pressure, that's fine. Again, there's a lot of fluctuations. We see this when we do stress tests on people. Your blood pressure should naturally go up with exercise, and that's normal. What we care about is the big picture. For the most part, spikes, you can have spikes from stress. If I'm on call all night and I don't sleep a wink and I have a bunch of coffee, I bet my blood pressure is higher or lower, depending on how the night went. But that's normal, and we all get one-off readings. That's why apps are nice, because they will graph it for you. But even just logs, you get a sense, and it's like kind of with anything, drop the high and the low and average the rest. So lipids. So hyperlipidemia is the medical term for high cholesterol. And you've all probably had your cholesterol checked. And a standard lipid panel is going to have these 4 components. It's going to have total cholesterol, triglycerides, HDL, and LDL. We used to care a lot about total cholesterol, and so some of you may kind of have this number in your head of like 200, like, am I above 200? Am I not? And that's like whether or not you're okay. And I would say that our management of cholesterol, actually more so than blood pressure for sure, has really changed over the last 10 to 20 years. So in order of importance is actually, and I put it this way because that's usually honestly how it's reported in your paperwork. What we actually care about the most is LDL, probably followed by HDL. These two can kind of be interchangeable, but these two are, and then I care the least about your total cholesterol. It doesn't give me a very good picture of what's going on with you. And so most of our focus, though, is really around the LDL. So a lot of people, so what should my cholesterol be if you're not saying this 200 number? So LDL. So pretty much everybody should have a normal LDL, which is less than 100. A nice way to think, I was listening to an American College of Cardiology podcast the other day, and there was a famous lipidologist, and she put it a nice way that the LDL, which is a low density particle of our cholesterol, it should kind of be viewed a little bit as a toxin, essentially. And so if you're being exposed to this toxin over years, it's going to increase your risk of heart attack and stroke. And we know that. That's why we care about LDL, because it's so tightly related to people's cardiovascular risk for heart attack and stroke. And so if my LDL is 90, it's going to take me quite a few years to have the same exposure as somebody whose LDL is 200. They're going to get there like twice as fast as me. So even if you don't have problems, it makes sense to at least normalize your LDL to reduce your risk down the road. Because the way we manage lipids is not for today or tomorrow. It's for the next 20, 30, 50, 60 years of your life. And that's really how the shift has gone. So much so that we don't even really look at the numbers as much as we try to look at you as a patient and try to decide, how high risk do I think you are for having a heart attack or a stroke? And then that tells me what your lipids should be, not the other way around. And that's really been a big shift. So everybody should have an LDL of less than 100. HDL, it should probably be greater than 40. That's a tough one. And it's not so much that we care less about it, but we can do very little about it. So we've got lots of medications, but I'll get to this in a minute. We have good medications that can lower LDL, and they do lower your cardiovascular risk. HDL is tough. We don't really have any medications that reliably increase somebody's HDL. But we do know that if you have a higher HDL, you have a lower risk. So that one's kind of on you. And that's where it comes with heart-healthy diet, regular cardiovascular exercise, and genetics does play a big role. There's some people that are doing like all the right stuff and their HDL is like 38 and they just can't get it any higher. And a lot of that is just genetics. There's other people that have HDLs of 90 and they're sitting on the couch eating potato chips. But it does tend to be pretty reflective of diet and exercise, and we just don't have a lot of meds as of yet that can target that. High risk. So that's for everyone. So if you're high risk, what does high risk mean? That means like you've had a heart attack, you've had a stroke. We think that based on your family history or your calcium score, some of this stuff that we'll talk about in a minute, we think that you're higher risk than the average bear. We should probably get your LDL lower. I think that cholesterol right now, as with a lot of things in technology and medicine, our ability to do things or obtain data often outpaces our knowledge base of what do we do with that information. And that's a little bit where we're at right now with cholesterol, I think, that we have the ability to get like all of this information, but we're not quite ready to know exactly what to do with it. And we're also limited by like, there's a lot we can't do about it, you know? So kind of similar to the HDL, like I don't really have a way to raise people's HDL, even though I know it would be good if I could, you know? So that's kind of where we're at, but I'll get to the lipid particle a little bit. So how do I know if I'm at risk for high cholesterol, I guess? So we kind of, going back to the like, are you a high risk or not high risk? So we kind of talked about this, like your family history. Do you have other things? Have you had an event? And then there's these risk calculators. I really hope that, So this is also a fun thing. If you're bored and you want to go on the American College of Cardiology website, there's this thing, and I have this app on my phone, so if you come seeing me in clinic and I look like all of a sudden I'm like texting my friends or something, or like, you know, getting on Instagram, I'm actually calculating your risk. So it's an app that I keep on my phone. And so this is a risk calculator. And this is kind of what I'm talking about that has really changed like how we manage lipids, because it's not perfect. And I'll get to this in a minute, but it's helpful in the sense that it takes into account like what's your age, what's your gender, do you smoke, what's your blood pressure, you know, yada, yada, yada. And then it spits out this number, which is a percentage. And so if you put it in, it'll spit out a number that says, you know, 7.5%. And then the question is like, well, what does that mean? So what that means, and there's two different things. It'll give you a lifetime risk, which is usually like some crazy high number, like 50%, which sounds horrible, but that's kind of the statistics. I mean, we know that like if we live long enough, most of us are going to have something. That's the number one killer. So it sounds crazy high, but don't let that get you down. You know, live long and prosper. But the 10% risk is kind of what we use to guide what do we do now. So the 10% risk, the 10-year risk rather, the 10-year risk, and that's what it'll spit out, is the way to think about that is if I have 100 people that are exactly like you and they look exactly like you on paper, how many of them are going to have a heart attack or a stroke in the next 10 years? And then if that number was 7.5%, then I'm going to expect 7 or 8 of them to have a heart attack. And then there's a place on this app that you can like plug in, like, well, what if I start a statin? What if I control your blood pressure? What if I do? That's a little bit less helpful, but that's kind of a good way to think about it. And then that compared, it'll also spit out something called your optimal risk. So these things are important because at some point, we're all going to get, and we consider above 10%, we consider you high risk. You know, 5 to 10 is like, and like 5 is pretty low. At some point, we're all going to get into that 10% category. And I counsel people about this a lot in clinic because it's kind of like, congratulations, you're 68. You've now outlived all the other things that were going to kill you. And looking forward for the next, you know, this is the most likely. And, you know, it's not across the board, but if you just look at, you know, if you're just going to play odds and just look at the data, that's kind of true. So for men, that tipping point, and this may change because that's a whole nother conversation about women and cardiovascular disease. But for men, that tipping point is usually somewhere around 60 to 70 that you kind of like fall into that category of like, yeah, you know, moving forward, you should, that's a risk for you. So you should probably be on a statin medication to lower your risk. For women, it's usually kind of 65 to 75-ish. But don't get depressed if your number comes back high. If you look at the optimal, if it's the same, then what that means is it's a lot driven by your age, which is great. Congratulations, you outlived all that other stuff. So because this stuff is preventable and manageable, and we can deal with it. So additional risk stratification. So there's a lot of patients, as I said, like this thing isn't perfect. The lipids aren't perfect, And so there's a lot of different ways that we try to get more granular about like, okay, well, not every person over 70 is going to have a heart attack or a stroke. No, that's true. Not everybody is. So how do we identify people that we think are at higher risk or lower risk? Or, if somebody's like, I really don't want to start a medication and my cholesterol is great, but I am 75. There's a lot of times. Or I'm 40 and, I have this awful family history. Like, should I be targeting an LDL of 100 or 50? So there's a lot of different situations where we want to know more. And there's no one way. The crystal ball has not yet been, FDA approved. So, but there are a lot of tests out there that give us a little bit more information. So some of those, and one that I use pretty often is called a coronary calcium score. So this is a CT scan that's done of your chest. And basically, when a plaque has been there long enough, it becomes calcified. And these calcified particles show up on X-ray. And then you can plug it into an algorithm and it'll spit out a number. And it'll say your calcium score is 0 or 500 or 1,000 or somewhere in the middle. And then more importantly, it will spit out a percentage. So it will say, your score is 100. Compared to other people your age and gender, you fall into the 0 to 25th percentile, or you're the average bear at 50%, or you're higher than the average and you're in the 95 to 100th percentile. And that's helpful to know how that relates to the aging thing, because if you have a score of 100, but you're 90 years old, you're pretty darn good. If you have a score of 100 and you're 35, you're a lot higher than the average person. So, it's all taken in context. And I also always counsel people that this screening test doesn't tell you if you have blockages. It doesn't tell us if you have narrowings in your heart arteries. And arguably calcified, not all plaques are made the same. So arguably calcified plaques are probably more stable for a lot of people. And it's the non-calcified soft plaques that we think cause the heart attacks. And so we also use this in the sense of where there's smoke, there's fire. If you have a lot of calcified plaque, you probably also have a lot of uncalcified plaque, soft plaque, risky plaque. So it's not perfect. Another test that you can get at the screening things, or you may have done yourself, is this carotid intimal thickness. Same idea, kind of. It looks at the essentially plaque buildup or thickness of the carotid artery. And that's been shown to have some correlation with the event risk. Lipid particles. So we can really get down to the weeds. You can do, electrophoresis and really get into all the small particles. The ones that are most commonly are LP little a and ApoB. And those are probably, they do have some benefit to knowing them kind of. I put them in the category of, if I need a tiebreaker type of thing, and that's kind of what I put all these things. If I've already got somebody on a statin, they've already had a heart attack, cat's out of the bag. There's no point in me doing this because you already declared yourself. But if I'm in that kind of tiebreaker, I don't know, how hard do we push? What do I think your risk is? These things can be helpful. None of them are perfect, but they can be helpful. Treatment. So diet. Diet's important. For most people, changing your diet, even if it's a drastic change, is probably not going to change your cholesterol a lot. I would say the exception is triglycerides. Those are highly dependent on your diet and alcohol, so that can be changed a lot. For a lot of people, if you have a pretty healthy diet, making it super duper uber healthy is probably not going to make a big difference, but it makes a little bit of a difference, and it's still important because it's not an either or. It's not if I have like a super healthy diet and lifestyle, then I don't need to take meds. Not true. And it's also not, if I take meds, I don't have to have a super healthy diet lifestyle. Not true. Both of them work together. So diet and statins. And then PCSK9 inhibitors. So statins have they've been around for a long time. They have a lot of bad press, a lot of good press that you don't hear anymore. They're good medications. We almost exclusively use, So in my mind, there's really only 2 statins worth taking anymore. So rosuvastatin is Crestor. Atorvastatin is Lipitor. These are the newest statins. They're the most potent, and they have the lowest side effect. I put simvastatin, or the lowest risk of side effects. I put simvastatin in with an asterisk because it does have some data that it's probably good, but some of the other weaker statins like pravastatin or like a really old statin called lovastatin, we just don't have the robust clinical data. And also I would put red yeast rice in that too. It's a form of a statin. So does it help? Probably. But do I have these huge hundreds of thousands of patients in a clinical trial to know that it does? I don't. And these ones will have the lowest risk of side effects and are the most potent. They're also generic, so they're cheap. Not everybody can tolerate statins for one reason or another. And so the nice thing is that we now do have an alternative. It used to be if you couldn't tolerate statins, we kind of got really artistic with how we managed it. But now we have these things called PCSK9 inhibitors, which are injectable medications, work in a totally different manner, and they really lower the cholesterol. But more importantly, and what we care about, is that they lower the risk of heart attack and stroke and dying of those things. Because there's other cholesterol medications. There's bile acid sequestrants and a lot of other things that lower your cholesterol, but they haven't been proven to lower the risk. So it's not just the cholesterol. And that's also what I counsel people about is that statins, they lower your cholesterol, but anymore, I almost think of that as a side effect or are you taking the med? I can tell you're taking it if your cholesterol is lower. They probably have some sort of anti-inflammatory, we think, property that they stabilize plaques. So it's more important, I have people, several times a year that have beautiful cholesterol, and unfortunately they had a heart attack. And they say, well, why am I on a cholesterol pill? And it's not because I need your cholesterol necessarily to be lower, but your plaques have proven that they're unstable, that they tend to rupture and cause heart attacks and strokes. And we know that being on a statin medication stabilizes it, makes it less likely to bust open and cause one of those problems. We've got about 5 to 10 minutes, so I'll kind of cruise through this other stuff. Heart failure, as we talked about, we categorize it into systolic and diastolic. Systolic means it doesn't pump well. Diastolic means it doesn't relax well. Ischemic is the most common form. So this goes back to that slide about the most common thing, the high prevalence of coronary artery disease. Most heart failure is ischemic, meaning it's related to coronary artery disease. So it's a problem with the plumbing ultimately. But then there's a lot of non-ischemic. And so this is like everything else. Things that can cause your heart muscle to be weak. Alcohol, high levels of alcohol, toxins, some chemotherapy agents, sometimes genetics. So there's a lot of genetic mutations of which we probably know maybe 30%, There's a lot of things that we don't know in that realm. Arrhythmias, so having like a really fast heart rate for a really long time is bad for your heart. And then this blanket statement of idiopathic, which is like, I don't know why. But there's a lot of things that can cause heart failure. I didn't put on here valve problems also. Valvular would be another common problem, like a structural problem. Diastolic heart failure is kind of a newer entity. The most common people we think about is women with high blood pressure. It's not just women. I don't know why it kind of got labeled that way. I see a lot of men with diastolic heart failure too, but it's pretty closely related to high blood pressure, sometimes being overweight, sometimes sleep apnea. And it's the clinical presentation, because heart failure is actually a clinical diagnosis, meaning that I don't need to know what your heart is doing to diagnose you with symptoms of heart failure. I look at you. I hear fluid in your lungs. I see swelling in your legs. I see that your neck veins are up. And then the looking at your heart tells me what type of heart failure it is. So this has kind of been recently diagnosed or recently given a better label. And I would say that we're still figuring out the best ways to treat that. We're kind of just using the same meds, but it is closely related to high blood pressure. Where we stand now with heart failure is that it's primarily medications that treat it. It's 5 meds combined into 4 pills. The 2 new kids on the block are Entresto, and then one of these medications that was actually designed for diabetes that they found actually help in heart failure. And then sometimes we put ICDs in or pace people, LVADs or our left ventricular assist device, and then transplant. And then arrhythmias, so, the electrical system. The types of arrhythmias that we see, the vast majority are what we call supraventricular. I don't think my picture is on here. Well, kind of. So supraventricular is something from these top chambers of the heart called the atria. That's including, so that's your AFib, your A-flutter, SVTs, Wolff-Parkinson White, all that stuff. Ventricular arrhythmias are much less common, but they can be dangerous, and they're often associated with problems with your plumbing, so blockages in heart arteries. The treatment for arrhythmias, and of that, like the vast majority that we see are AFib or flutter or SVT. I'm sure everybody knows somebody who has one of these things. Medications can treat it. Cardioversions is where we shock you out of an abnormal rhythm back into a normal rhythm. And then ablations are procedures where we go actually up into the heart chambers with these little catheters, and we map out these electrical circuits to figure out where the arrhythmia is coming from. And we actually create little scars, which is depicted here with this white line. And it's a scar to basically isolate that misbehaving bunch of cells that's wanting to do its own thing so that it can't communicate with the rest of the electrical system of the heart. So I'll kind of pause here real quick before I give my own personal plug. So if you haven't met us all, this is our team at Vail Health, and honestly, we're able to care for the whole house. The whole heart is what I call it. So you've got 2 plumbers. So Jerry, Dr. Greenberg and I are plumbers. Dr. Prager is an electrician. And then we all, including Dr. Sherman, who's primarily over in Summit County, and Kelly, who's primarily here, can manage like the medical treatment of heart failure, arrhythmias, coronary artery disease. We're constantly growing what we're able to do, both from a diagnostic and a therapeutic stance. So we can do calcium scoring CT scans. I didn't talk a lot about cardiac rehab, but honestly, it's phenomenal. Our cardiac rehab group up here is fantastic. It's growing. I think every meeting that we have, which is like once a month, they get to show their slides. It's like, we've grown 200%. And then it makes all of us be like, well, okay, that's like hard to compete with, but they're like growing by leaps and bounds, and they do great. We have a brand new facility; it's gorgeous. Diagnostics, we can do basically every type of stress test, and then coronary CTA, I didn't talk about, but it's a very cool type of study. That's a specific type of CAT scan or CT scan that is much more similar to a stress test than like that calcium scoring thing, and it's the closest thing we have so far to having like a heart cath or like an invasive procedure. And it's pretty darn good. So we have the ability to do that up here, which is fantastic. Because honestly, that's pretty new. And some of the analysis that we do with that, I mean, that's hot off the press. Where I was before, we were the first place in Colorado to get it. And that was within the last 5 years. So we're crushing that. Interventional cardiology, we do stents, angioplasty. We help manage and diagnose pulmonary hypertension, and then we do ablations, pacemakers, cardioversions. So that's kind of us. So as like a quick, because I don't have time to go into this, but the one thing I didn't mention is that we do have a new service line. So this is something that I started when I came up here a year ago, and it's the management of peripheral artery disease. So it's a new service line that we have at Vail, where we're able to, like all that plumbing stuff that I talked about, the heart arteries, I mean, they're special, but they're not that special. So it happens in other arteries. And so we're able to manage it with procedures and medications and walking therapy and all those things when it happens in other places. And so that's a big focus of mine. My practice is pretty 50-50 split between peripheral disease and coronary disease. And so that's something that that we are able to do here. Ooh, this is actually an important thing. People think of, and so most of the stuff that applies for cardiac disease will also apply to this. I also love this slide. People think of vascular disease as being just like something that like men get. And honestly, people think about cardiac disease the same. And in vascular disease, we know that peripheral artery disease, gender is not a risk factor. And I suspect that we'll probably get there with coronary disease too. I think we're just underdiagnosing it and undertreating it. And it's a very well-known and documented thing that, if a woman comes to the ER with chest pain, it takes her longer to get an EKG, and it takes her longer to get the care, and she has a worse outcome. And so that's like a big push, and that's a big push everywhere, but also at Vail Health. And honestly, we've started tracking it, and we're really improving it, which warms my heart. But it's awesome. We're really like making a good progress with that. But so PAD, ABI, sorry, I'll just so that you know what we're talking about. So this is some of the stuff that we've just started doing up here. And it's basically when people have blockages in their leg arteries, they can present with pain, they can present with wounds. And it's not just like a quality of life thing. If you have a wound that's not healing, you're at risk of losing your leg. If you lose your leg, you don't live as long. That's just, the statistics. And so we're able, so like for this woman, she had a toenail removed and eventually came and saw me because it just like never healed. And she was missing this entire artery, which we were able to open it up. And it's the whole artery that goes from her groin all the way down to her knee. So that's the kind of stuff that we do, and we're rocking and rolling with that, doing a lot of cases. So I will skip to my favorite slide. Not that one. Thank you. Oh, and I said save a limb, save a life because of the thing about if you lose your leg, then you're at higher risk. So these are what I do in my spare time. These are my two kiddos. I would love to answer whatever questions, concerns, comments, criticism